Hello, everyone. We would like to present Dr. Alex Cahana from New York directly for you, live from New York. He's the founder of BTblock Health Group. Dr. Alex, off to you.
Good morning, everyone. It's a pleasure to be here. And thank you, Akil, for the kind invitation. I always enjoy presenting at your excellent conferences. Okay, so today I'll be talking about which token is best for decentralized health. Some call it Health 3.0 or health in the era of Web 3.0. And I'll be discussing a little bit experiments with different types of tokens, utility, security, stable, personal, social, and non-fungible tokens. I wear many hats, but for the sake of this conversation, I will speak mostly about my work and policy work through the United Nations and the European and African Unions. So a little bit about myself. I've been a pain specialist for quite a while. I've been involved in technology integration since it was considered a thing. I've built 5, 6 pain centers around the world, so it's safe to say that I'm familiar with the global healthcare system. I've been extremely involved and intrigued, or some say seen the light, in blockchain and cryptocurrencies since 2014. And as I mentioned, I serve on policy advisory, and by the virtue of my work, see simply a lot of projects in blockchain and healthcare. And not surprisingly, I was proud to be the co-editor of the HIMSS publication textbook called Blockchain in Healthcare. So in order to talk about decentralized health, I think we should try to understand first what is centralized health. And one easy way of understanding it is that despite the fact that we would like to talk about centralized data, it's actually centralized data silos. Our health records, which are our interface into the data world, are all over the place. We can find them in hospitals and clinics and labs. Now we have many wearables. Some use direct-to-consumer genomics. We have our claims information that regards to our health insurance, and many of us in most part of the world, we use paper records. And actually, the healthcare system in the U.S. is one of the only systems that still uses paper records and fax machines, and we're the most important industry that still keeps fax technology live. So this centralized data silos creates problems. Many of the problems that people have experienced on a personal level is the lack of interoperability. We have to walk from one clinic to another. More importantly, in the back end, there's really no incentives to share between the various stakeholders. The only incentives really are for the patient that wants to seek information, but it's not as if there are rigid and robust economic incentives where the various stakeholders will feel that they have to share this information, and many times IP stands in the way. And so healthcare suffers really the basic problem is data illiquidity. And since we are in a DeFi conference, and since we are most of the audience thinking about, I would say, information and money, I do recommend everyone to think about data as, every time I mention the word data, really is dollars, and that the currency, so to speak, would be data, and we will speak a little bit later about the monetization of that data. But the fundamental problem of centralized health and the lack of sustainability of it is really the problem of data illiquidity and the problem of information asymmetry, where simply we do not know things either as consumers or as providers. So it's not surprising that there are multiple solutions or multiple stakeholders inside the healthcare data ecosystem to, so to speak, solve the problem of illiquidity. We have multiple electronic healthcare softwares in the US. I think there are over 1,200 of them, where 5 basically hold 80% of the market. There are data lakes in the distribution and pharmacy and claim clearinghouses. Like I mentioned before, multiple wearables that are out there, information exchanges. There are services that are used to try to help either on the front end for patients to understand actionable information, but most of them really sit on the back end with enterprise data warehouses and data aggregators that the average person simply has never heard of. But if you work in the industry, if you work in medical devices or pharmaceuticals, or if you work for a state or federal government, then clearly you're familiar with these large aggregators. And all in all, this is a multi-billion-dollar industry. And unfortunately, the information asymmetry is dependent and many times exploited on these type of solutions, quote unquote. And I just want to give here one type of third-party solution, an intermediary solution. It doesn't, it's not the only one. There are also third-party administrators. There are also purchase group organizations. But I wanted to bring pharmacy benefit managers because everybody understands, at least in the US, the lack of access to medication in a reasonable price. And so pharmacy benefit managers, who you see here, the gentleman in red, was supposed to be the person or the entity that would solve that problem of exorbitant prices. And the idea was that they would negotiate either with payers or with the drug makers or directly with pharmacies and consumers a better price. And this is in order to solve the problem where a hospital or a payer cannot really go to each and every drug maker and negotiate a best price, or that a pharmacy cannot go to each and every drug maker or through a wholesaler to negotiate a price. And so they're supposed to find the best price for you. But unfortunately, a unbalanced ecosystem, an unbalanced business model does not incentivize them to translate their negotiation ability that would represent a lower price for consumers. And a lot of times, pharmacy benefit managers, and there are only 3 large ones in the US that capture the majority of the market. Most of the time they keep the benefits of lower pricing that they were able to negotiate and pocket them themselves. And that's the famous spread game that we talk about. So when there is information asymmetry and a consumer does not know the real price, or there's no mechanisms for price discovery, you can find that the third parties that are in the middle not only create I would say friction or capital leakage, but also cause the opposite effect of making the system more expensive. And so it's not surprising that the US here is an outlier when you look at life expectancy on the y-axis and the cost per capita, the health expenditure per person on the x-axis. You see that the value is low, that the healthcare expenditure in the US is extremely expensive. And this is also true before COVID and especially after COVID, where systematically in the last 6 years, life expectancy in the US has been in decline. And obviously there are many reasons to it, but the point that I wanted to make here was that the increase in prices and the increase of types of treatments and tests and healthcare consumption has not translated in any significant way to improved outcomes. So if we understand the limitations of centralized health, not only in the sense that it is cyber vulnerable and collusion vulnerable and censorship vulnerable, and everyone has heard and read about ransomware, that has been rampant in the healthcare system. It's important to understand that decentralized health, when I talk about it, really is based on having self-sovereign identity, and which causes the patient not only to be the center, but also to be the driver of the whole economic system. And this is something that is a new concept that I hope some of you in the audience will embrace and will be the main message of this talk, is that although we talk about value-based and patient centricity, really what is important is to allow the patient to give them access to their data, ownership to their data, and their ability to give access or revoke that access to different parties. So the way this would look like is that on a mobile structure, for example, I would be able to give my doctor access to my information as a viewer or an editor or a commentator. I could get access to hospital. I could decide what an insurance company can see, who can see it, when they can see it. I can be directly in touch with payment providers and not through third-party intermediaries. And to some extent, if, for example, there are D2C supplies, I can control that supply just like when I buy on Amazon. And if I wish, and this is a very interesting topic that is moving forward, also provide personally my information for research and not through third parties, like, for example, now my genomic data has been sold to pharmaceuticals or to third parties without my expressed permission, or without my, I would say, informed consent, because I wasn't really realizing that in page 27 in font 3, I would forfeit my ownership on that information. And this information can be tokenized, and I'm not saying that everything needs to be tokenized, but there is an interesting way, and I'll talk a little bit later about the advantage of tokenizing it. But decentralized health, in essence, is a patient-driven healthcare system which transforms the relationship that patients have with the various stakeholders in healthcare. So for clarity in this discussion, I wanted to highlight what is the difference between a coin and a token. We use that very interchangeably, but they're not exactly the same. It is confusing because both of them are considered units of accounting and medium of exchange, and both of them, to some extent, are store of value, although most tokens, if not all the tokens, and there are about 24 of them in healthcare, have lost significant value on exchanges. The major difference is, from a practical perspective, is that coins, because they are built into the blockchain, into a chain, their chain, and their own protocol, are used really as sources of payments, whereas tokens can be used for payments, but many times are used to sign digital agreements. So, for example, this access or revocation of access to data, the ability to decide how to incentivize or reward users for certain behaviors, all these can appear in smart contracts and represent, as a token, the intrinsic value of the community that is using that specific project. It starts to become confusing because in the, I would say, 7-8 years that we've been looking at the token, I would say, economy, and going through multiple phases of how to fund many of these projects, there are now multiple tokens out there. And really the propos of this conversation is to kind of say, okay, which one would be the best? Are we talking about utility tokens? Are we talking about stable coins? And if these are stable coins, what kind of stable coins can be used? Are we talking about currencies and coins, or are we talking about NFTs, which now have become very, very, I would say, more popular or in the central conscious of users? Or do we just pay for medical services in Bitcoin, like, for example, now in El Salvador? So I think that in healthcare, the easiest way to think of mostly tokens is that this is a peer-to-peer network technology that minimizes the need for trust agents. As I mentioned, there are many trust agents that are used as third parties to solve problems. So there are many brokers, there are many billers. Anybody who knows in healthcare, the revenue cycle management knows that there's a lot of friction involved in the transfer of money that causes a disconnect between the end user, which is the patient, and really where the money flows. And as you can already imagine, I alluded to the fact that patients are not part of that economic activity. And when I talk about trust agents, I don't talk about trusting me because I'm a nice person or what Alex saying sounds really, really interesting, but really about computational trust, which lowers cost, of course, because if we look, for example, at VoIP, Voice over Internet Protocol, that has reduced the cost of calling on the phone, especially for long distance, to a nominal price. And now many of us use telephony and use the phone for practically for free. And so in the equivalent of VoIP, we can think about the different types of economies where also data over Internet Protocol can be moved from place to place with minimal fees. And of course, the money over Internet Protocol or programmable money, where we can incentivize the different stakeholders within the system to behave in a certain way or to encourage certain behaviors and discourage other behaviors. The emerging blockchain uses in healthcare have become quite, I would say, known or solidified ever since the COVID pandemic. Everyone has seen the limitations of it. Everyone has seen its ability or inability to perform and understands that there are problems in terms of the supply chain, in terms of digital identity, things that we want to understand through clinical research and how to access that data and monetize on it, and how do we keep the system viable in terms of financial and insurance records. So we've found that this sensitive information is not used in a way that solves the problem of data illiquidity. And if anything, COVID has shown the frailty of the current system and really has pushed forward the recognition that there are multiple solutions now that make sense to be used in healthcare. And I say many times that we have jumped at least a decade forward thanks to this global pandemic. So one example here where this can be tokenized is for self-sovereign identity. So if we want to look, for example, at credentialing of healthcare professionals, well, this is, again, a very big industry that allows cross-state or cross-border movement of healthcare professionals, where usually these professionals are issued an identity, and there are those who need to verify that identity so they can work there. And right now, the system is extremely expensive. It's labor intensive. It takes multiple times. And so, for example, during the COVID pandemic, the way in the US that we solved this problem was not to embrace a self-sovereign identity solution, but rather to create these legal waivers where you can just go in and suddenly you're allowed to do things that in normal times that would not be the case. But of course, that is not necessary. And there are technology solutions. And by putting, for example, your identity in and registered through an access that is in a smart contract on a blockchain, where the data itself is centralized or issued by a centralized institution and is stored in an identity hub, which can be centralized or decentralized. That's a separate conversation. But a person a professional can have that ID at their fingertips, and that actually the presentation of their identity was as simple as scanning a QR code, and the verification of it by the hospital or the clinic or whoever needs it can be straightforward. And so the technology actually exists. Tokenization hopefully would accelerate the use of it. The same thing goes for tracking not people but tracking material. We see here again that there is a multiple step for material, anywhere through manufacturers and distributors that could be regional or secondary, all the way to the healthcare provider. That material is identified again through a QR code, and the reporting can be given to different agencies, again, based where the identity in this case would be the manufacturer, and the control over access and a revocation of that access could be directly controlled, and all this could be, of course, geolocated and geotagged. And this would ensure not only privacy and authenticity, but also provenance and compliance, and we could enforce these digital protocols and reporting to the public agencies. And when you combine the two, when you track people and you track things, then you really get a supply chain, a value chain. And this would be, for example, in the case of vaccinations, where personal data through a pre-health assessment can be entered and creating a QR code that is unique to the person, and the vaccine itself can be married to that unique patient QR, and the ongoing monitoring then can be applied through business intelligence and provided to different agencies, again, with the rigor of using data that is immutable and I would say time-stamped and able to be audited in a way that would allow compliance and research. Decentralized clinical trials is another use. Anybody who knows this knows that the problem with decentralized trials is that it is very expensive, and for sponsors, for drug manufacturers or device manufacturers, it's very difficult for them to assure the adherence to these various protocols. And so again, through the same structure of a patient-driven system, they can be incentivized through tokenization and complete and adhere to trials. And this is not, when you hear about decentralized clinical trials, most talk about the remote follow-up on it, but really it's about the distributed and decentralized architecture of the data that makes it decentralized. And of course, what I think is really the game changer, and this is where we've been working very hard in Africa, is to create patient-owned personal or electronic health records, where not only are they self-sovereign, but also they provide monetary and non-monetary incentives to behave in healthy ways. So you can encourage wearing a mask, and you can encourage getting a vaccine. And this can be through providing actual cash or to provide access to services that otherwise would have been cost prohibitive. And from there comes a concept that I coined called universal health income, which allows people to either create an income or complement their own income based on positive and healthy, sustainable behaviors. Tokenization can also be used to create different communities, and they can be professional communities, they could be research communities, and again, leveraging the capabilities of a decentralized system using verifiable credentials. One can apply through tokenization different types of voting or reputation systems, and as I mentioned, can be rewarded. So there's a lot of flexible ways to encourage not only individuals, but how these individuals interact and how they capture their own value within a community of peers. And this can be well translated into wealth, and it could be connected or completely disconnected from a local currency. And this is, again, an example that was in Africa, where it is not pegged to the local currency, but where labor, education, health, and the local economy all can be connected through, if you wish, some type of electronic bartering or a reward system that is based on distributed ledger technology. So to answer the question, and we're getting towards the end of our talk, to answer the question, which token is the best for a healthcare system, I think the three ways to answer them is to say, first of all, what is the business model that we want to create? What is the economic dimension that we want to capture? Right now, I hope I was able to convince you that this information asymmetry and exclusionary extractive economy is not sustainable, where there are huge winners and a lot of losers. And you can see that especially in COVID, where there are stakeholders that are making tons of money and where others are really crushed. So it is a asymmetrical and imbalanced ecosystem. We can look at the technological dimensions. If it's a layer 1 or layer 2 application, probably for the time being, most of them would be on top of a blockchain, so a layer 2 solution. So we're talking more about tokens than rather native coins to healthcare, although it's possible to start paying for health with cryptocurrencies. And the idea of legal dimensions that pertain to IP and the tightness of that IP. Do I own it? Do I have rights for it indefinitely? Do I have revocable rights? And so to determine really the legal aspects of what is allowed or disallowed. And so, for example, in the US, utility tokens are not allowed, so it's simply not a tool in our toolbox. So there's those type of considerations. And so the question is, if we want to create non-monetary and monetary rewards, and this could be for patients or for doctors or any industry member, probably utility tokens, where it's allowed, are the most useful type of useful type of tokens, and stable coins can be used as a payment system. When we look at revenue cycle management, when it will be permissible, then stable coins or cryptocurrencies could replace that with the advantages of using it. I imagine that some of you are thinking about the volatility of it. I just want to remind you that the volatility is really when it is compared to the US dollar. Right now, for example, in El Salvador, people buy with Satoshis, and simply that's what it costs. And compared to the fluctuations of prices in their exchange rate to the dollar, the use of Bitcoin had made the US dollar not as a replacement, but actually irrelevant for their local economy. NFTs, or be it personal coins or social coins, are a very interesting solution that are now being explored and experimented for credentialing or creation of either content or IP. Its uniqueness and its immutability to define a certain time-stamped character is what makes it so interesting and versatile. As I mentioned, as we start to create these communities, these distributed autonomous organizations voting in it and creating governance tokens that would represent the typology of the interactions between the members and capturing their internal values would be of interest. And I put this last, fractional ownership, not because it's not an interesting idea. I think it is a huge, important way of spreading the wealth or increasing the economic activity. But right now, scrutiny, legislative scrutiny or regulatory scrutiny really has made the use of security tokens a bit more challenging. So in general, and this is the end of my talk, I would say that crypto assets, be it coins or tokens, are simply a new way to trade data or a new way to do business. It's a different business than what we are right now used to doing in healthcare. And as I mentioned, the use of that in Africa can actually help them leapfrog in all emerging markets into new ways of doing things for lack of incumbents, for a more flexible regulatory landscape. I think that healthcare would be wise to look at what is happening in financial markets. Both markets have sensitive data. They require high trust and privacy. And so to try to emulate or translate different types of elements in DeFi would be helpful to do the same in healthcare. And this is my last slide. Really, the idea is that if we containerize data, then we make it like money. It is yours. It is private. You need to keep it securely in a wallet. You can use it whenever you want, wherever you want, for whatever reason. If you can do it in a way that you can quantify it, then you can trade it and you can exchange it. You can invest into it. You might inherit it to your family and friends or donate it to society at large. So it's really a different way of looking at data. And what this causes eventually is that we are transforming people from being right now, which they are, health service consumers, to actually people who are able to produce their health and their wealth through tokens and coins. Thank you very much.